The second type of ameloblastoma is the unicystic ameloblastoma, which is similar to dentigerous cyst. This ameloblastoma is the second and far less frequent growth pattern seen in the intraosseous ameloblastoma. The most common mutation seen is BRAFVG00E. Then it has the minimum criterion for the diagnosing a cystic ameloblastoma is the demonstration of a single cyst sac odontogenic ameloblastomatous epithelium found only in the focal areas, that is not seen anywhere generalized, it's present only in one single area. Then when we look into the gender, it is seen more in males. When the tooth is impacted, the cases are slightly higher. But when you see in females, it is seen in non-impacted tooth where the cases are slightly more. Regarding the age, when we look into the age of the patient, he is usually a younger age patient, that is around 22 years or 22.1 years of average. Location, it's usually seen in the mandible near the third molar region. This is the mandible and here's the third molar and here's the tumor. It moves first from the region, it will start to the ascending ramus, then it moves towards the body and then towards the symphysis. It is seen in the interradicular or peripheral region and in the edentulous patients. Means in the interradicular region where the two roots are there in the tooth, between those two it is seen usually, and it is reduced in incidence of recurrence is seen here. Moving on to the histological features, we follow a criteria, it's a particular criteria called the Vickers and the Gorlin criteria. In this there are three. Like one is the luminal unicystic ameloblastoma, intraluminal and mural. What happens here is luminal unicystic ameloblastoma, the tumor is confined into the lumen, means it doesn't go outside the lumen. In the intraluminal, where the name suggests it's outside the lumen, we have seen the proliferation usually occurs in the epithelium into the lumen without infiltration of the tumor cells. When we look on into the mural part, the usually growth of the epithelium into the connective tissue is seen and the islands into the connective tissue wall is seen. And usually mural we do resection, but here no resection is required. Okay. Then moving on to some of features like how the cells will look. The cells will be usually colloidal, columnar, basal cells. Okay, so this is the epithelium. Suppose the basal cells will be usually cuboidal or columnar. Okay, these will be the cells like this. Suppose if it is there, and the nucleus is hyperchromatic nucleus, that is most, it will be dark, you can see dark purple color. Okay, then there's a reverse polarity of the nucleus, that is at the periphery. Before the nucleus will be here, during development it will go here, so that is towards the periphery. That is called the reversal of the polarity of the nucleus. Then the cytoplasmic vacuolation with the intercellular spacing, here you can see there's a spacing between, this is present. Then you can see epithelial hyalization and all will be occurring here. Now suppose if this is the tumor like this, you can see here a thin layer of stellate reticulum will be there, and this will be the basal cell layer. Okay. Now when we move on to the treatment and prognosis, one thing you can do is resection, that is the complete removal will result in the cure. Then when we move on, the surgical plan, it should be influenced by the lesions as the maxilla and mandible. If it's in maxilla, then it will have calcaneous bones, means it has porosities and all in the bones. So the spread of the tumor occurs there. But in the mandible, the cortical plates which are present in the mandible limits the spread of the tumor. Regardlessly the tumor, the long-term follow-up of the patient is absolutely necessary. That's all for today. Thank you. In the next class, we will be looking into the histological classification of the ameloblastoma.